In this recording, I will go over Chapter 58, Coronal Polishing. In this chapter, we'll explain the difference between prophylaxis and coronal polishing and the indications and contraindications to a coronal polish. We'll name and describe the types of extrinsic stains, the categories of intrinsic stains, and the methods we can use to remove plaque and stains. We'll identify the handpieces and attachments that are used for coronal polishing and look at why we need to select an appropriate polishing agent. We'll look at the materials to avoid when polishing and describe the technique for polishing aesthetic restorations. Finally, you'll see a video on the coronal polishing procedure. So what is coronal polishing? It is not oral prophylaxis or prophy or cleaning. A prophy is the complete removal of calculus, debris, stain, and plaque from the teeth. Coronal polishing only removes plaque and stains from the coronal surfaces of the teeth. In Texas, a dental assistant may perform coronal polishing after completing 2 years of clinical experience and taking an 8-hour course approved by the Texas State Board of Dental Examiners. We selectively polish only areas of the teeth or surfaces that have stains. We want to avoid removing even small amounts of surface enamel. Some patients may experience dental hypersensitivity during and after having coronal polishing done. So it is important to discuss with the dentist what should and should not be polished. It has always been thought that we need to polish teeth to remove soft deposits and stains before applying fluoride. It was believed that there would be a greater uptake of the fluoride into the enamel. However, we now know that polishing doesn't improve the uptake of fluoride. What are some of the benefits of coronal polishing? Polishing with pumice, a non-fluoridated abrasive, is important before sealant placement. It also helps prepare the teeth for placing orthodontic brackets and bands. Smooth surfaces are easier to clean, and patients will appreciate the smooth feeling and clean appearance. Coronal polishing can have damaging effects on the tooth surfaces and the gingival tissues and restorations. Box 58.2 on page 908 in your textbook goes into detail on these damaging effects. When should we perform coronal polishing? Before we place dental sealants and orthodontic bands, before placing a dental dam, before applying an acid etching solution on the enamel, and before cementing crowns and bridges. When should we not perform coronal polishing? When there is no staining on the teeth. On patients who are at a high risk for caries because small amounts of enamel are removed during polishing. Also, if the patient has sensitive teeth, because the abrasive agents in polishing can increase areas of sensitivity. Patients with newly erupted teeth should not have coronal polishing because mineralization of the surfaces of these new teeth may not be complete. Stains are primarily an aesthetic problem. Some types of stains can be removed and others cannot. That is why it is important for you as a dental assistant to be able to correctly identify stains. If stains cannot be removed, there are other treatment options, including professional and at-home bleaching procedures, enamel microabrasion, and placing of laminate veneers and composite restorations. There are two categories of stains, endogenous and exogenous. Examples of endogenous stains include those caused by an excessive amount of fluoride during the formation of the tooth. Another example of an endogenous stain would be one resulting from medications taken by the mother or child during tooth development. Exogenous stains are stains caused mainly by environmental factors. They can be either extrinsic or intrinsic, depending on whether the stain can be removed. Extrinsic stains are on the exterior of the tooth. These stains can be removed because the stain is external. These stains can be caused by food, drinks, such as red wine, soft drinks, and tobacco. Intrinsic stains cannot be removed because the stain is incorporated into the structure of the tooth. Examples of intrinsic stains are tobacco stains from smoking, chewing, or dipping, and from dental amalgam that has become incorporated into the tooth structure. There are several methods of removing plaque and stain. The use of air-powered polishing can be an efficient way to remove stains quickly and thoroughly. The operator can control the flow rate, leading to differences in abrasion. Another method is rubber cup polishing. This is the most common technique for removing stains. The rate at which appropriately chosen stain and plaque are removed depends on the abrasiveness of the polishing paste, the pressure applied to the rubber cup against the tooth, the length of time required for polishing, and the technique used to perform the polishing. Polishing cups come already attached to a disposable prophy angle or must be newly attached to a reusable, re-sterilized prophy angle heads for each use. The items B and C in the picture show a polishing cup that can be attached to a prophy head angle. Picture D shows a disposable rubber cup and prophy angle. Disposable prophy angles with attached cups come in a variety of shapes, colors, sizes, and materials. Item A in the picture shows a bristle brush. Bristle brushes can be used to remove stains in deep pits and fissures on the enamel surfaces. They can cause severe laceration to the gingiva and must be used with special care. They should only be used on sound enamel and not on exposed cementum or dentin. Items C and D in the picture are prophy angles. C is a reusable prophy angle and must be cleaned and sterilized after each use. D is a disposable prophy angle which is discarded after use. When attaching the polishing cup or brush to the reusable type of prophy angle, you must ensure the polishing cup or brush is securely fastened. If a polishing cup or brush falls off during the procedure, the patient could swallow or aspirate it. A proper grasp is important for control of the handpiece and the pressure that is exerted on each tooth. The proper grasp for the handpiece and prophy angle is the pen grasp. Like the name suggests, you hold the handpiece and prophy angle like a pen or pencil, with the handle of the handpiece resting in the V-shaped area of the hand between the thumb and index finger. It is important to have a proper grasp. If the grasp is not secure and comfortable, the weight and balance of the handpiece can cause hand fatigue and wrist fatigue. There are handpieces available that are light and easy to hold, which helps to ensure little hand and wrist fatigue. To operate the handpiece, you will use the rheostat or foot pedal. This pedal controls the speed of the handpiece. Use your toe to activate the rheostat with your sole remaining flat on the floor. You will use a slow, steady pressure with your toe to produce a slow, even speed. Release the rheostat between teeth to ensure that the revolving prophy cup or brush tip is not caught on a patient's intraoral soft tissues. The operator should always try to position the fulcrum close to the tooth being worked on. The operator should be sure to change the fulcrum position as needed with each tooth so as not to strain his or her fingers and to provide the best support possible to the handpiece. Your fulcrum may be intraoral or inside the mouth or extraoral outside the mouth, depending on a variety of circumstances, such as the area of the mouth being polished and the patient's ability to widen the mouth when open. In choosing the appropriate abrasive, the dental assistant must try to select the one that will be the least harmful to the enamel or restorative surface while still providing enough abrasion to remove the targeted stains and plaque. Polishing agents come in extra coarse, coarse, medium, fine, and extra fine grits. Table 58.3 on page 913 in your textbook lists some commonly used abrasives. Just remember, the goal is always to use the abrasive agent that will produce the least amount of abrasion to the tooth surface. Improper polishing can quickly damage aesthetic restorations. You must be able to identify and differentiate between tooth structure and restorative materials. Using an explorer to examine the margins and the outline of the tooth surface and relying on just feel can help you differentiate between tooth structure and restorations. Other ways are to look at the patient's radiographs. Remember, restorations appear radiopaque or gray to white on an X-ray. You also can review the patient's dental record to identify restorations. Pressure from the handpiece will affect the rate of abrasion. Remember, the lighter the pressure, the less abrasion to the tooth surface. Using a fulcrum on a nearby tooth will help you control the amount of pressure used. Rheostats have varying sensitivities. Test the sensitivity of the rheostat in controlling the handpiece speed outside of the mouth and away from the patient first. It is very important for the dental assistant to place the fulcrum finger close to the tooth on which he or she is working for better control of the handpiece. The polishing stroke consists of a patting and wiping motion with overlapping strokes. Using the slowest speed possible, start at the gingival third and pat swipe up to the incisal third of the tooth. The cup should be flared to adapt to contours, especially in the interproximal areas where most plaque and stain tend to build up. Positioning of the patient is very important. Adjust the chair so that the patient is approximately parallel to the floor with the back of the chair slightly raised. Make sure the headrest is adjusted for patient comfort and operator visibility. Positioning the mandibular arch parallel to the floor when open for instrumentation purposes allows for better placement of the light and for direct vision in some areas. The picture on the top shows positioning for the mandibular arch. Positioning the maxillary arch for instrumentation with the chin up almost places the maxilla perpendicular to the floor, allowing better light placement and access for instrumentation. The picture on the bottom shows the positioning for the maxillary arch. Operator positioning is important for support, comfort, and safety. Keep your feet on the floor and thighs parallel to the floor. Your arms should be at waist level and even with your patient's mouth. Keep your fulcrum as close to the area you are polishing as possible, preferably on the same dental arch. You should be seated in an 8 to 9 o'clock position for right-handed operators or a 3 or 4 o'clock position for left-handed operators. One effective sequence is described in Procedure 58.1 on pages 917 through 919. It is best to complete one arch before the other, if possible, because of the different headrest adjustments that are needed. It is also recommended that all buccal or lingual surfaces of one quadrant or sextant be polished before you advance to the next surface, because the various surfaces require different positioning. Remember to polish the aesthetic restorations first with the finer polishing agent before completing the rest of the mouth. As always, you should review the patient's medical history for any contraindications before performing coronal polishing. If the patient is wearing a removable denture or partial plate, this may be a good time to offer a complimentary cleaning of the prosthesis by placing it in the ultrasonic cleaner. Always inform before you perform. Make sure you explain the procedure before you begin and answer any questions. You should report any suspicious intraoral lesions to the dentist. Some lesions may need further follow-up, and others may be contraindications to coronal polishing at that time. Before starting the polishing, use a disclosing agent to identify areas of plaque. These are areas that you will need to pay particular attention to when polishing. Please go to Lecture Section 14 on Blackboard and click on the link for the coronal polishing video. The last thing you need to do is floss after polishing. This serves two purposes. First, to polish the interproximal tooth surfaces, and second, to remove any abrasive agent or debris lodged in the contact areas. Be sure to ask the patient whether he or she can feel any remaining polish from between the teeth. If a patient had a tremendous amount of plaque between his or her teeth, this may be a good time to review the proper use of floss. Lastly, you need to check to see if there are any remaining disclosing agent or any abrasive agent left on the teeth. You may wish to reapply the disclosing agent after polishing to see whether any plaque remains that requires additional polishing before dismissing your patient. Ask the patient to run his or her tongue over the surfaces of the teeth to feel the difference after polishing. Have the dentist discuss other alternatives, such as at-home vital bleaching, that may help the aesthetically conscious patient achieve whiter teeth. Many patients do not realize how some foods, drinks such as coffee, tea, and soft drinks, and tobacco contribute to initial extrinsic tooth staining. Educate the patient about these issues. If you have any questions, please email them to me or join me for my office hours on Wednesday from 7 to 8 p.m.